والثانيه شعبان.
بسم الله الرحمن الرحيم. I'm very thankful for this excellent conference, and I'm thankful for all my professors, I'm my professor chairman in this interactive session, for Ibrahim Radwan, for Hassan Gouda, and for Atf al-Qarb. The first question in this interactive will be, what the most common pathogen causing community-acquired pneumonia are Haemophilus influenza, Streptococcus pneumoniae, Mycoplasma pneumonia, Chlamydia pneumonia, all of the above. Now vote now. Yes, I see that the floor chooses Streptococcus pneumoniae the commonest pathogens. What we mean pathogens بالجمع يعني. Pathogens. So Ibrahim Radwan will comment on this picture, please.
بس مش معنى الترتيب سلايد ده يعني اللي هو Streptococcus pneumoniae هو most common بيوصل ل 60% تقريبا، بعدها هيموفيلس انفلونزا، وبعدين الايتيبيكال زي المايكوبلازما نيمونيا والكلاميديا نيمونيا دول اقل يعني.
Second question, please. On the other hand, we know that the commonest pathogen causing nosocomial pneumonia, gram-negative bacilli, gram-positive cocci, anaerobes, viral infection, atypical organism. The most common for nosocomial pneumonia now. I think this question is the best question. Most common gram-negative bacilli, and Dr. Hassan Gouda will comment on this answer.
Yes, of course, gram-negative bacilli, nosocomial pneumonia is the common. Nosocomial pneumonia is pneumonia that develops at least 72 hours after respiration. You may get some of these pathogenic as well, but the most common is gram-negative.
Yes, okay. Next, please. The third question, diagnosis of atypical pneumonia should be suspected in the following situation except extrapulmonary symptoms, low-grade fever, basal infiltrates in X-ray, response to beta-lactam antibiotic, positive serodiagnosis. يعني كلهم صح ما عدا واحدة هي اللي ما بنقولش عليها في الحالة دي atypical pneumonia. Yes, this question is also right. The response to beta-lactam antibiotic is one of not recommended manifestation of atypical pneumonia, and Professor Atf al-Qarb will be comment on this question, please.
كلمة atypical pneumonia كان زمان ده كلمة يعني موجودة ومباشرة لغاية دلوقتي، إن هي atypical كان تقول typical حاجات زي Streptococcus pneumoniae زي موبس انفلونزا زي البورتيلا والحاجات الباقية اللي بيحكموا إن هي atypical، كانوا بيفتكروا إن الحاجات الباقية دي ان هي نقود بكتيريا فيراي على الاورجانيزم، هي زي المايكوبلازما وزي الانيزلا وزي الكلاميديا. لو شفنا الاجابات اللي قدامنا حضراتكم اكسترابلمونري سيمبتوم طبعا دي موجوده في الحاكم الديواني قال دلوقتي عنها، اللي زي الانيميا زي الراش زي الديبريشن زي النيكروجيكال زي الجي اي بي امبيكسيا. اللو جريد فيبر دي بتكون موجوده برضه في النيمونيا. البيزل انفلتريتس بتكون غالبا بيزل، بتكون غالبا بايلاترال، وتكون غالبا مش لوبر. بحيث ان اللوبر الا في الليت ستيج ممكن توصل لأكثر في اللوبر. الريسبونس تو بيتا لاكتام انتيبيوتكس ده متوقع لان في بعضهم مش تلك لاكتام، يعني المايكوبلازما ملهاش وول من الاساس ومش هيشتغل عليها البيتا لاكتام. في حاجات بتكون جميله بتكون انترا سيلولار اورجانيزم او برضه ما اشتغلش عليها البيتا لاكتام، ويكون فيهم بوزيتيف سيرو دايجنوز موجود في معظمهم كل حاجه لها سبيسيفيك تيست.
نشكر الحضور اللي شرفونا في الجلسات دي. ان شاء الله الفوتنج باك بليز نوصلها للدكتور حسام ونشكركم ونكمل حضرتك مع الشركه.
Thank you for this session. Before we begin the next session, create a company in the quiz and في 4 هدايا حلوين 3 قدامنا منهم. الهدية الرابعة 4 هدايا والهدية الثالثة تلفزيون.
قبل ما ابتدي الحقيقه بحب اشكر اللجنه المنظمه على دعوتنا للحضور المؤتمر، واللي هو الحقيقه كل سنه بنحضره بنلاقي فيه تقدم وتحسن عن المؤتمر اللي قبليه، فبنشكرهم وبنتمنى لهم طبعا من التقدم والازدهار. النهارده هنتكلم عن pulmonary hypertension classification, pathophysiology and diagnosis. الباثوفيسيولوجي الحقيقه هقوله بسرعه على انه مفيش حاجه نيو فيها، لكن هنتكلم على الكلاسيفيكيشنز اللي حصل فيها في السنتين الاخرانيين، نيو advent in the classification of the pulmonary hypertension. كلكم عارفين الباثوجينيسيس عباره عن vasoconstriction وريموديلنج اند ثرومبوزيس. دي السيمبوزيا اللي اتعملت في خلال السنوات اللي فاتت وحصل فيها كلاسيفيكيشنز مختلفه للبالمونري هايبرتنشن. اول واحد كان جنيفا 73 واسموها برايمري وسكندري، وبعد كده ايفيان، وبعد كده جه فينيس اللي هو قسمها للخمس حاجات المشهوره اللي هنشوفها بعد كده دلوقتي، الفايف جروبس المشهورين. وبعد كده اللي هي دانا في لوس انجلوس 2008 وحطوا الكلاسيفيكيشن اللي انا هوريه لكم دلوقتي. و2009 اتعمل دانا بوينت ثانيه واتعمل اكدوا الكلاسيفيكيشن اللي عملوه، واتعمل نيو في الاي ار اس انكوربوريشن مع الاوروبيان هارت اسوشيشن، وتقريبا كان الكلاسيفيكيشن اللي هو الاخراني الفايف جروبس اللي هنتكلم عليهم بعد كده. في امبورتنت ديفينيشن نقولها لازم، ان البالمونري هايبرتنشن از هيمودايناميك اند باثوفيسيولوجيكال كونديشن defined as increase in the mean pulmonary arterial pressure اكتر من 25 ملم mercury at rest assessed by right cardiac catheterization. وفي multiple condition clinical condition responsible for pulmonary hypertension. الديفينيشن القديم اللي هو اكتر من 30 at 25 at rest و 30 at exercise خلاص not valid now. Pulmonary hypertension include different forms share similar clinical picture and virtually identical pathological changes زي ما هنشوف بعد كده. ده الديفينيشن القديم اللي اتعمل سنه 71 واللي قلت not valid now. ده الديفينيشن الجديد اللي هو approved now، ان عندنا ان يكون المين pulmonary artery مش اكتر من 25 ما لهمش دعوه ريسك، ان البالمونري كابيلاري بريشر يكون اقل من 15، وطبعا الكاردياك اوتبوت لا اما نورمال لا اما يبقى impaired. عشان نفرقه ده اللي بري كابيلاري pulmonary hypertension. في only one type of post capillary اللي هو secondary to cardiac causes، سواء كانت diastolic systolic dysfunction or valvular disease، وده بيبقى فيها زيه بالظبط الاكثر من 25 25. هنا المختلف عنه ان pulmonary capillary wedge pressure اكثر من 15 عشان ده post capillary، والكاردياك اوتبوت maybe normal or impaired. ده the latest classification of the pulmonary hypertension in 5 groups. pulmonary arterial hypertension و pulmonary arterial hypertension second to left ventricular dysfunction, pulmonary hypertension second to lung disease, chronic thromboembolic pulmonary hypertension and miscellaneous causes. التغيير اللي حصل كان طبعا في برايمري بقى اسمه ايديوباثيك، كان في فاميليال سموها دلوقتي هيريتابل بالمونري هايبرتنشن، وفيها حاجتين مشهورين طبعا اللي هو بوم مورفوجينيتيك ريسبتور 2 و اكتيف لايك ريسبتور كاينيز اي. وبعدين دراج انديوز اشهرهم طبعا انوركسوجينيك دراجز واسوشيت ويز ذا فولوينج كونديشن. طبعا الكونكتيف تيشو ديزيزز، الاتش اي في، البورتال هايبرتنشن والليفر سيروزس، سيستميك شنط يعني يكون عيان عنده ايزنمنجر سندروم. الشيستومايسيس الحقيقه البرازيز دي دخلت جديد ما كانتش موجوده، والهيموليتيك انيمياز دخلت جديد ما كانتش موجوده. كان في القديمه البالمونري فين اوكلوسيف ديزيز كان انكلودد ان ذا جروب 1، دلوقتي خرج من جروب 1 زي ما هنعرف ليه، لانه صحيح هو بري كابيلاري انما هو ميبي كومبليكيتد. لو انا اديت زي ما هنشوف فاسكولار دايليتيشن او عملت فازور اكتيفيتي ممكن عيان يخش في بالمونري اديما. هو مختلف تماما لانه بيأفكت صحيح من الفينيولا لكن بيأفكت الارتريز في نفس الوقت، عشان كده خرجوه وعملوه 1 داش مش في الجروب 1. جروب 2 قلنا كاردياك سواء كان سيستوليك دايستوليك او فالفولار ديزيز، دي ديفرنت كوزز pulmonary causes of pulmonary hypertension، ودي chronic thromboembolic، ودي condition associated with pulmonary hypertension، الهيماتولوجيك disease، systemic disorders زي الفاسكولايتل، metabolic disease، congenital heart disease and other causes. ده the last classification of pulmonary hypertension. الاوائل اللي بنسميه pulmonary arterial hypertension كلهم بري كابيلاري ما عدا تايب 1 اللي هو 2 اللي هو بوست كابيلاري سكند تو ليفت كاردياك ديسفانكشن. اللي هي الديفرنت باث ويز اللي كلكم عارفينها، سواء كان اندوثيلين باث واي او ناتريك اوكسايد باث واي او بروستاسايكلين، واعتقد الدكتور مجدي هيتاكل دي في المانجمنت اوف ذا تريتمنت اوف بالمونري هايبرتنشن. في غير الكيولوجيكال كلاسيفيكيشن في فانكشنال كلاسيفيكيشن according to New York Lung Association قسمت الفانكشنال كلاسيفيكيشن into 4 types. Class 1 no limitations of activities, Class 2 slight limitation of activity, comfortable at rest, Class 3 marked limitation of physical activity لكن عند الريست كويس. طبعا Class 4 بيبقى marked affection with right ventricular failure and low cardiac output. Therefore functional classifications of the pulmonary hypertension دي هتبقى important قوي بعد كده في المانجمنت زي ما هنشوف بعد كده. طبعا البروجنوز والسرفايفل كل ما كان العيان ستيج جريد 1 غير 2 غير 3 غير 4. clinical presentation of pulmonary hypertension حقيقة actually there is no specific present symptoms for pulmonary hypertension، انما في early there is no early manifestations. The first sign may be progressive dyspnea put in the differential diagnosis of unexplained dyspnea and easy fatigability. If the disease progresses, the patient may have pain, may have some syncope. If delayed, we have some manifestation of right ventricular failure, edema, and ascites. This is the clinical manifestation of pulmonary hypertension. Early, there is no manifestation. Lately, the manifestation of right ventricular dysfunctions, neck veins, accentuated second sound, and so on. مش عارف الصورة دي عاملة كده ايه، مش عارف. نعم؟ الكمبيوتر ما راهاش فانا مش عارف اقراها يعني. اوكي يعني طبعا هي دي كانت الالجوريزم هاو ان انا بروسيد الحقيقه ان مانجمنت اوف ذا بالمونري هايبرتنشن. يعني على لكم الذاكره هو طبعا بنحاول نشوف السيمتوم والساينز لو وجدناها انها كومباتيبل مع هبروسيد. الكومنز 2 عندي اللي هم الليفت فنتريكل اند لانجز، وهيهاف ان انا سيرش فيهم بعمل زي ما نشوف بعد كده اكس راي اي سي جي ايكو اف كاتش دايجنوزس، يبقى انا شخصت الحاله انها كاردياك او بالمونري. اف نو اي هاف تو بيرفورم لانج سكان، واكوردنج تو لانج سكان اف اي بوزيتيف يبقى ده بنسميه كرونيك ثرومبوامبوليك. اف نوت I have to search for the etiology of the pulmonary hypertension. How can I determine the risk of pulmonary hypertension? عندي low risk and high risk. low risk لو في clinical evidence of right ventricular failure لو موجود يبقى high risk. لو في progression of symptom إذا كان rapid يبقى في high risk. الجريد بتاعت الكلاسيفيكيشن لو هي 4 هيبقى high risk، طبعا لو 2 أو 3 هبقى low risk. 6 minute walk distance لو هي اكتر من 400 يبقى لو ريسك، لو اقل من 400 يبقى هاي ريسك. لو في البيك ابتيك اوف اوكسجين كان عالي ده في هاي ريسك. لو عملنا ايكو للعيان ده وكان في بريكاردال افيوجن ايفيدنس اوف رايت فنتريكولار امبيرمنت رايت اتريال انلارجمنت يبقى العيان ده اوف هاي ريسك. الهيمودايناميك لو انكريز اكتر من 20 في الرايت اتريال بريشر والكاردياك اندكس اقل من 20 لتر بير مينيت بالمتر سكوير هيبقى هاي ريسك. لو عملنا بعض الماركر زي بيتا ناتريتك بروتين وجبناه فيري هاي، ده significantly هاي، ده indicate high risk of the patient. دي how can I proceed في الدياجنوزيس of the pulmonary arterial hypertension. باخد الاول الهيستوري والاكزامينيشن والاكس راي تشيست والاي سي جي. if suggestive it's okay, if not دي بيرايز دي هاي اندكس اوف سسبشن. بعد كده بعمل ايكو كارديوجرافي واشوف الايكو ترانس ايكو واكسرسايز ايكو، وده هيكان جيف مي سم انديكيشن. وده زي ما قلنا الايكو از سكريننج تيست بس از نوت اكيوريت، ممكن يبقى عالي ممكن يبقى واطي، واعمل رايت كاردياك كاسترايزيشن ويطلع حاجه مختلفه. زي ما قلنا بنعمل فنتليشن برفيوجن لانج سكان. لو كان سسبكتد ممكن اعمل بالمونري انجيوجرافي او مالتي سلايس بارا سي تي انجيوجرافي عشان اشخص اللي بنسميها سي تي اي بي اتش اللي هي كرونيك ثرومبو امبوليك بالمونري هايبرتنشن. بعمل بالمونري فانكشن تيست وارتيال بلاد جازس. بعمل اوفر نايت اوكسيمتري عشان لو عنده obstructive سليب ابنيا ودي ريسبونسبل فور one of the respiratory causes responsible for pulmonary hypertension. بعمل طبعا اتش اي في. بعمل some collagen vascular profile to diagnose some collagen vascular disorders. بعمل liver function test to diagnose portopulmonary hypertension. بعمل some functional assessment زي 6 minute walk test. lastly و most important الحقيقه اللي هو الرايت كاردياك كاسترايزيشن. بعمل عشان اشخص الاول pulmonary arterial hypertension، وبعمل فازو رياكتيف تيست زي ما نشوف بعد كده عشان اشوف عنده ريسبوندنج ولا نون ريسبونسيف عشان التريتمنت بعد كده. وبعمل اكسرسايز تيست بشوف الرايت كاردياك كاسترايزيشن لو انا شكيت في الرايت في الليفت سايد. دي الحاجات اللي انا بعملها عشان اشخص الاكس راي تشيست الاي سي جي بتاعي والبالمونري فانكشن تيست. دي كلاسيك اكس راي تشيست في حاله الادفانسد بالمونري هايبرتنشن اللي هي of course enlargement of the hilum, pruning of the periphery and enlargement of the right ventricle. ECG changes in the form of right axis deviation, incomplete right bundle branch bronch and right ventricular strain. الايكو هارت for diagnosis. دي sequence of events اللي كان في الاخر خالص تديني portal hypertension وincreased contractility وincrease in the diastolic volume ending by decreased stroke volume ischemia and right ventricular failure. دي الحاجات الحقيقه ان انا كتبتها. طبعا احنا ما بنعملش ايكو كارديوجرافي، انما هتلاقي عندنا الكارديولوجيست اللي بيعملوا ايكو كارديوجرافي انه بيركزوا على حاجات مختلفه تماما عن اللي احنا بنبقى طالبينها. بيركزوا على الليفت فنتريكل، بيركزوا في حاجات معينه لازم يركز عليها الكارديولوجيست اللي بيعمل الايكو. لازم يركز على الرايت سايد اوف ذا هارت، لازم يركز على توتال اكسبانشن اندكس، لازم يتكلم على حاجه اسمها ترايكاسبيد انيولار بلين سيستوليك اكسكرشن اسمها تيبسي، يتكلم على ترايكاسبيد ريجارد، يتكلم على السايز اوف ذا ليفت فنتريكل اند رايت فنتريكل. دي التيبسي او الترايكاسبيد انيولار بلين اكسكرشن اند اتس ريليشن تو كل ما كانت ازيد كل ما كانت السرفايفل والبروجنوزيس احسن. يبقى زي ما قلنا الايكو ريمين ذا موست امبورتنت نون انفيسيف دايجنوستيك تول. الاكيورسي بتاعته ليميتد وكونفيرميشن لازم اعمل رايت هارت كاسترايزيشن عشان كونفيرم بريزنس اوف ذا pulmonary hypertension بيفور ستارتنج التريتمنت. البالمونري فينو اوكلوزيف ديزيز زي ما قلنا قبل كده طلعناها في جروب لوحدها، انها بتشير البالمونري ارتيريال بريشر هي والبالمونري هيمانجيوماتوزيس نفس الباثولوجي بتاعهم. present some clinical similarities with the pulmonary arterial hypertension, however phenotyping quite different عنهم خالص. worse prognosis. التريتمنت بتاعهم هو الترانسبلانتيشن. سبيسيفيك طبعا ثيرابي اللي متعودين عليه في البالمونري ارتيريال هايبرتنشن may complicate pulmonary venous disease by pulmonary edema. بشخصها ازاي؟ طبعا ان انا طبعا الجولد ستاندرد نعمل بايوبسي، لكن ممكن اعمل اشخصها ريتروجريد لو عنده خد فينو بازو اكتيف ويحصل له كومبليكيشن، او اعمل له بال والاقي فيه فيري هاي هيموسيدرين ليدن ماكروفاجز. دي اللي هي السي تي بيكتشر مش حلوه قوي معلش، او دي بالمونري فينو اوكلوزيف ديزيز بقى فيها ثلاث حاجات: جراوند جلاس ابييرنس وسيبتال لاين اند ميدياستاينال ليمفادينوباثي. دي العيان بعد ما خد الفازودايليتور حصل له complicated by pulmonary edema. ده diagnostic approach for diagnosis of chronic thromboembolic pulmonary hypertension. البيشنت with unexplained hypertension pulmonary hypertension بعمل له ventilation perfusion lung scan. لو نورمال يبقى ده ما هواش CTEF. لو في abnormalities بعمل له further study by multi-stage spiral CT angiography MRI angiography. لو هو طلع يبقى دون CTEF او chronic thromboembolic pulmonary hypertension. دي طبعا السكان ده اللي هو المالتي-سلايس CT angiography. دي موزايك ابييرنس موجوده في CTEF. دي اجين الموزايك ابييرنس. من اساس الاكسرسايز كاباسيتي باي طبعا ال6 مينت ووك تيست. الاول مستعمل البيز لاين وبعد كده بنفول العيان during treatment to assess the response to treatment. دي clinical correlation between the 6 minute walk test and the prognosis. طبعا the more the 6 minute walk test اكتر من 322 او اكتر من 400 the better the prognosis. right cardiac heart catheterization is very important. بتتعمل طبعا بالجاجولار ابروتش. لازم نعمل الاول الانتي كواجوليشن. بنعمل فينا اساس ثرو الجاجولار ابروتش وبنعمل بالسوانجان كاستر وين اسيس الديفرنت كونديشن الرايت ارتريال بريشر الرايت فنتريكل المين بالمونري ارتري بريشر بالمونري كابيلاري ويدج بريشر الكاردياك اوت الميكسد فينس اوكسجين تنشن. طبعا مهمه جدا برضو pulmonary right cardiac catheterization to perform vasoreactivity. الفازو اكتيفيتي بنعملها بناتريك اوكسايد ونشوف الريسبونس بتاع العيان للناتريك اوكسايد. دي سوانجانز كاستر ده الناتريك اوكسايد ماشين يوز فور ستادي. الفازو اكتيفيتي بندي طبعا الناتريك اوكسايد او بعض الدراجز زي الايوبروستينول او الادينوزين او الاليوبروست ونشوف الريسبونس بتاع البيشنت. طبعا بنعتبر الريسبونس لو حصل دروب في المين ارتيريال بريشر اكتر من 10 ملم ميركوري فروم ذا بيز لاين ويكون بلو 40 ملم ميركوري. هنا بنعتبر هذا العيان حصل فازو اكتيف ريسبونس. يبقى العيان ده ريسبونسيف تو تريتمنت ممكن ياخد كالسيوم بلوكر زي ما دكتور مجدي هيقول لكم بعد كده. So pH is now defined by means of pulmonary hypertension more than 25 ملم mercury at rest. ادانا بوينت كلاسيفيكيشن من 10 من جروبس اللي قلناهم اللي هم pulmonary arterial hypertension والسب تايب بتاعها pulmonary venous occlusive disease. تايب 2 pulmonary hypertension lead to left ventricular dysfunction. تايب 3 pulmonary hypertension lead to respiratory disorder. تايب 4 thromboembolic pulmonary hypertension. تايب 5 اللي هو الميثيلينيوس فورم. Echocardiography remain the most important non-invasive diagnostic tool but accuracy is limited. Right heart catheterization is considered mandatory prior to treatment and for follow-up observation. Right heart catheterization should include full hemodynamic assessment and vasoreactive test when appropriate treatment is required. ده يعني summary for management. ان انا بعمل الاول عيان بعمل له فازو اكتيف رياكشن. لو هو بوزيتيف بدي كالسيوم شانل بلوكر. if not لو له ريسك بدي تريتمنت معينه الدكتور مجدي هيقول لكم عليها. لو هاي ريسك اللي قلنا عليها بندي تريتمنت معينه تانية. ثانك يو.
طبعا بنشكر الدكتور الفاضل الدكتور مجدي. هي هو اليوناني فيري ويل واقف وزي ما انتم شايفين ان هو والحقيقه بناء على الضغط الشغل كده هنحدد المانجمنت كمان الريس او حاجات او راحه للبريبريشن. هو الحاجه الوحيد اللي موجود دلوقتي لكن هو حاجه موضوع انا حابب دلوقتي ان قبل ما اقدم اخونا الفاضل الصديق العزيز الدكتور طارق صفا انا بهني الدكتور طارق صفا والدكتور طارق حفوظ وكل لجنه منظمه وكل الطب كلها قصه الصدر كله على المؤتمر الناجح والحضور الجميل. وطبعا الفاضل الاستاذ طارق محمد غني عن التعريف، هو مش بس هو رئيس جمعيه الجينيكولوجي، هو صديق عزيز وحبيب اعتقد لكل الديتيشن ومش بس بالذات لكل الاطباء في مصر والبيولوجي سواء اولهم. اهلا بيك ليه وسعداء بوجودك معانا. هيكلمنا الدكتور طارق طبعا عن الفارمولي ديتيشن. بروفيسور طارق.
شكرا دكتور سمير على المقدمة الجميلة دي، ربنا يخليك. شكرا. My task to talk about the non-pH. احنا عرفنا زي ما الاستاذ الدكتور مجدي اتكلم، الدكتور مدحت عبد الخالق، ان احنا عندنا دلوقتي كلاسيفيكيشن. البي اتش لما بنتكلم عليها اللي هي جروب 1، وبعد النون بي اتش اللي هي جروب 2 اللي هي بالنسبه للهارت بروبلم، خصوصا الحاجات اللي فيها ليفت سايد بروبلم في الهارت فانكشن. وبقى عندنا الثيرد جروب اللي هي الجروب بتاعت البروبلم بتاعت السي او بي دي، انفيزيما، انترستيشن لانج ديزيز. وبقى عندنا جروب 4 اللي هي بتهمنا قوي في حالات اللي هي كرونيك ثرومبو امبوليك هايبرتنشن. فبس just to review a few points معاكم، ان لما بنتكلم على البالمر hypertension it means that we have a PAP, the pulmonary arterial pressure mean more than 25 millimeter mercury. Below 20 millimeter that's normal. لما بنتكلم ان ده 24 it's indefinite. More than 25 it's definitely في pulmonary hypertension. The pulmonary capillary water pressure should be less than 15. دلوقتي according to the European Society of Cardiology guidelines التاسك فورس بتاعتهم والاي ار اس guidelines 2009 ان ما بقاش في بي اتش on exercise as a mean of more than 30 millimeter mercury as assessed by right heart catheterization is not supported by published data, and healthy individuals can reach much higher values. كان في الاولد definition كان في ان احنا ممكن نقول ان هو لو اكتر من 30 millimeter mercury في الاكسرسايز it means that this patient has pulmonary hypertension. Now in the new definition we don't include that. ان زي ما قلنا if you go through exercise you can develop a pulmonary pressure more than 30. What should raise the suspicion? I'm not going to go through all these details, لكن we have complaints, we have signs like loud second pulmonary pressure, ECG changes. وبقى عندنا risk factor. اللي عنده سكليروديرما should be checked every year by echo. اللي عندهم portal hypertension خصوصا portal pulmonary hypertension. اللي عاملين liver transplant. ال HIV infection الحمد لله ما عندناش فيها مصر حالات قليلة جدا. It's a whole list which we should evaluate and recognize and appreciate في ال definition with a suspicion بتاعتها. النيها classification, the new heart association classification, Dr. Medhat mentioned this, but I'm going to revise this point again. And طبعا pulmonary hypertension is a difficult task. It's a difficult problem. We have always to put it in our mind that this patient could have this kind of problem. So this is the classification. Class 1, no limitation of physical activity, and the patient doesn't have actually angio symptoms. Class 2, the patient has slight limitation of physical activity, but is comfortable at rest, and ordinary physical activity results in symptoms. Class 3, in the marked limitation of physical activity, however, he is comfortable at rest, but less than ordinary activity, which can cause symptoms. And the class 4, that's the most serious, that's the cardiac insufficiency at rest. If any physical activity is undertaken, discomfort is increased. فدي النيها بيسموها نيها classification. A progression of pulmonary hypertension, mind you, even if you have a straight pulmonary pressure, it doesn't mean that this patient has good prognosis. Even if you're evaluating your patient regularly by echo, this patient could develop at rest and on exercise a drop in his cardiac output. So we have to remind that we have to have in this kind of patients that we have to have a right heart catheterization. At least we have to suspect that you can get a drop in the pressures and in the cardiac output. Physical examination is very important. The signs of pulmonary hypertension, we all know it. The signs of decompensation, we have to check it. And signs, of course, indicating the cause of PH should be evaluated as well. So we have to remember these items. The procedures, we're familiar with the procedures as well. If we're suspecting pulmonary hypertension, we have to look for the symptoms, physical examination, screening, etc. Detection by ECG, X-rays, and transthoracic echo. Identification with PFTs, ABGs, perfusion scans, etc., and pulmonary angiography. And the last but not least, the evaluation by blood test, immunology, HIVs. And exercise test is very important. It's a very easy test, the 6-minute walk test. And usually the patient should have more, to have a normal 6-minute walk test, you have to have more than 360 meters in your 6 minutes. If you get it more below that, you have to evaluate the patient in your studies. This has been shown previously. You get a right axis deviation, the ECG, and incomplete right branch block, and ST segment changes. And we have to appreciate as well the problem with the pulmonary conus here, with the enlarged pulmonary segment and the enlarged right lower lobe artery. And it's very important as well to check the retrosternal contact area of the right ventricle. It's a large one with the enlarged of the right ventricle. The echo is very important. We have to calculate as well the T index, and we have to remember that the right ventricle in pulmonary hypertension is big, and it's pushing the interventricular septum downwards, and we have a small left ventricle. These are the classification of pulmonary hypertension, the old one, and then the Geneva 73, and then the EVM 98, and then we have the Venice 03. And mind you that here the secondary pulmonary hypertension is definitely abundant. We don't mention now secondary pulmonary hypertension. Either you have a PAH. When we say PAH, that's the group 1. Non-PH, that's the other 4 groups. And the last classification, that's the latest, and Dr. Medhat has mentioned it, that's the Dana Point classification. That's the update 08, and it has been classified all these into the 5 classes. And I'm going to just revise with you the class 2, 3, and 4. These are the main armamentarium we use in the PAH group, which is the class 1. When we say PAH, that's the group 1. That's the endothelin receptor antagonist, the phosphodiesterase inhibitors like the sildenafil, prostanoids, that's the prostaglandins and prostacyclin, and we can have a combination. That's for the group 1, not for the group 2, 3, and 4. I'm going to just revise this with you. If we have a left heart disease class 2, there was a study, that's the FLOLAN study, or the first study, that's the FLOLAN International Randomized Survival Trial, and the rationale of this study was to check the prognosis. Is it dependent? Is the prognosis dependent on PAP more than on the left ventricular ejection fraction? The prostacyclin, is it beneficial for patients with pulmonary vasculopathy, idiopathic pulmonary arterial hypertension? That's the rationale why they proceeded with this study. Scleroderma group associated with PAH, and the method was to give an open label trial with an IV epoprostenol, that's the vasodilator, in patients with severe left heart failure and pulmonary hypertension, and the primary endpoint was the survival. That was the conclusion of this study, that an IV epoprostenol therapy is not associated with improvement in distance walk, quality of life, or morbid events, and is associated with an increased risk of death. So this was condemned. We don't use the vasodilators in class 2. But we have to target the circle of underlying disease by the revascularization, valve operation, ACE inhibitors, resynchronization, heart transplant, and here the prostacyclin is definitely contraindicated in group 2. Our group, that's the major group in our practice, that's the class 3. Of course, we know the emphysema, cor pulmonale, all the group of COPD, interstitial lung disease. But when we mention interstitial lung disease, that's the group of the UIPs and NSIPs, not the group of interstitial or vascular problems. we're talking about the interstitial lung disease, the UIPs and NSIPs, and the hypothesis was that if you, the pulmonary hypertension in this group, that if you have alveolar hypoxia, you get a hypoxic vasoconstriction followed by hypertension, cor pulmonale, and death. However, another hypothesis was mentioned that it's not only the COPD which produced the hypoxic pulmonary vasoconstriction followed by pulmonary hypertension, but other factors can play a role, like cardiac left ventricular dysfunction, diastolic dysfunction, drugs like beta agonists and cephallin, and the breathing mechanics. We should consider these in our practice in pulmonary hypertension for the class group 3. Reasons why vasodilators are not working in this group: that you can get a ventilation perfusion mismatch, you can get a negative inotropic effects with the vasodilators, a systemic pressure drop, an edema formation. It could be wrong vasodilators, wrong patient population, and wrong underlying hypothesis. So the major treatment in this group, the class 3, is to optimize our therapy of the underlying disease. We have to quit smoking, bronchial therapy, dilators, optimize measure of exacerbation, avoid hypoxia. If you know that this patient has chronic respiratory insufficiency, avoid altitudes. Oxygen should be supplied in the airplanes, long-term oxygen therapy, CPAP, BiPAPs, etc. And medical therapy like PAH is only in evidence C. It's only for the patients which have out of proportion pulmonary hypertension, more than 45 millimeter mercury, 50, 60. But this should be in very specialized centers. So we should avoid this medical PAH therapy in the class 3. Lung transplant is in evidence C as well. We have another population in the group 3, which is the population having pulmonary fibrosis and emphysema. And to understand that if you have a PAP systolic pressure less than 45, more or less you have a good survival, maybe a better survival rate than the patients having a pulmonary pressure more than 45. Those having more than 45 millimeter mercury, their survival rate is about 30%, compared to those below 45, about 60 to 70%. So is it a good medication, or is it a wrong medication to use the inhaled prostanoids in this condition, which is the group 3? Inhaled prostanoids have been used. We can use them in ARDS. They drop the PAP decrease, no systemic arterial pressure decrease. They can redistribute the blood flow to the ventilated areas, can improve oxygenation, and same pulmonary and intrapulmonary selectivity as inhaled nitric oxide. But we have to remember that you can get a problem with the patients having interstitial lung disease, which is the shunting effect. So in this group, you can develop a right to left shunt, which can be a problem in your management for those kind of patients. So using the inhaled prostanoids in patients having interstitial lung disease is still a question mark, unless your patient has an out of proportion pulmonary pressure more than 45 millimeter mercury. Again, sildenafil, which is the Viagra, is it indicated, or is it a good or a wrong medication? Sildenafil in lung fibrosis associated with pulmonary hypertension. There was a MIGID analysis with the swine gas to see how many, the shunting effect. Unfortunately, the paper was only on a very few patients, about 16, and in this paper they used nitric oxide application or oral sildenafil, and they measured the gas exchange and the shunting effect, and they found that the intravenous prostacyclin has had a major problem causing a right to left shunt compared to the inhaled nitric oxide and sildenafil. Still, there is a shunt effect, but the shunt was worse with the prostacyclin group. So the take-home message, we have to remember that in this group you can develop a shunt effect with the vasodilators. Treatment with vasodilators is not recommended because they may impair the gas exchange, right to left shunt. Published data with specific PAH drug therapy is scarce. I mean, using the PAH group, which Dr. Magdi is going to address it for you, the endothelin receptor antagonist, the sildenafil group, and the prostacyclin. The data we have are really scarce, and patients with out of proportion due to the pulmonary hypertension due to lung disease with a mean pressure more than 45 millimeters expressed should be referred. If we're going to use this group of PH treatment in this class 3, we have to enroll those patients in an expert center and enroll them in clinical trials targeting the pH-specific drug therapy. We can't give this kind of treatment to those patients as an outpatient. You have to enroll them and follow them in specialized centers. Class 4 is very important. We see a lot of cases of pulmonary embolism, chronic thromboembolic pulmonary hypertension. That's class 4. The main target is to anticoagulate the patient with an INR 2.5 to 3.5. Evaluation for pulmonary endarterectomy is important, but we have contraindication. Unfortunately, this surgery is a major one. It's not popular in our country, and it has, of course, a high mortality rate. However, we have contraindication for this surgery if you have a peripheral type of CTEPH, if it's non-correctable left ventricular dysfunction, if you have a non-correctable severe obstruction or restriction, and if you have a contraindication, because you have to follow these patients with anticoagulation. So if you have a contraindication for anticoagulation, you cannot proceed with an endarterectomy. And usually you have to have a double, at least 2 projection in your pulmonary angio. And of course, the clot should be central. If it's a peripheral clot, this is not the goal, or this is not the preferred line of treatment. If non-operable, so you rely to the medical therapy, and that's evidence C, or if it's really disabling the patient, you can put this patient into the group of lung transplant. That's the group of the University Center San Diego, and they are very popular in doing this kind of surgery since the mid-90s. The pulmonary thromboendarterectomy, mind you, it's a very tough surgery. Sildenafil for long-term treatment of non-operable chronic thromboembolic pulmonary hypertension has been studied, and it gave quite good results. If we're looking here at the pulmonary vascular resistance, it dropped compared to the control group, and the 6-minute walk test improved with the sildenafil group. But mind you, that was a small number of patients, only 12. That's my conclusion and take-home message. My last final slide. If you're looking for a treatment of non-PH, again, non-PH, that's the group 2 to 5. If the treatment of non-PH should be considered in out of proportion PH in COPD or interstitial lung disease in expert. When we say out of proportion, which means that you have a pressure more than 45 millimeter mercury. And it should be considered as well if you have a non-operable CTEPH, again in an expert center. The treatment of underlying disease should always be optimized. We have to look to stratify our treatment and to give our regular treatment, anticoagulation, bronchodilators, infection, the standard treatment, long-term oxygen therapy, etc. And that's which should always be optimized before the start of PH target treatment. Thank you so much for your attention.
Assalamu alaikum again. So the last part is now talking about the management of group 1, which is the PAH, the pulmonary arterial hypertension. Now let me just remind you about about a couple of points, because these are very important to understand the pathophysiology of the disease and how it really progressed. That the PVR, the pulmonary vascular resistance, increased gradually over time, and as a matter of fact, that's the hallmark of the disease. The hallmark of the disease is where there is progressive increase in the PVR. Now the pulmonary artery pressure, I think I need to be clear here, it has no value in following the patient. It's only important to diagnose the condition. However, the cardiac output, which will be declining in future because of the progressive increase in the PVR, is what kills the patient. So the patient died because of the dropping in the right ventricular cardiac output and the abnormal filling or diminished filling of the left ventricle. And if you look at it, this is why actually most people die. If you look at the combination of low cardiac output, right ventricular failure, that's the end stage of the game. I don't need to repeat this because the 5 classes now are there clear to you. Let's concentrate on the PAH group, that are group 1. And again, to remind you that the mortality of this condition is extremely high, that the median survival is only 2.8 years. And again, reminding you that this is worse than most kind of cancer that you will deal with. And actually, when we talk with our governmental authority to release the medication, that's the way we approach them, because these drugs are very expensive, and we said, hey, look, you are dealing with malignant, basically, disease. It's very killer, and unfortunately, those who died are young patients. So, how can we assess the prognosis of the patients? Again, we start with the functional classes. Now, the data is very clear that those patients who are in functional class 3 or 4, when you start treatment, they do far worse than those who are in functional class 1 or 2. So the earlier you pick them, the better the prognosis. Furthermore, if the patient failed to improve after 3 months of treatment with basically prostacyclin treatment, again, those patients do not do very well, and the mortality is much higher than those who improve with treatment to class 1 or 2 in YHA. 6 minutes walk distance. I would say that's the endpoint that's used in 99% of the clinical trials, because it reflects the exercise performance, endurance of the patient, and it reflects the cardiac output. The more the patient can walk, you assume that that's the better cardiac output they have. And now we know, as Professor Midhat said, that if the patient cannot walk for 330 meters initially, that's not a good sign. And those people have worse outcome than those who can walk more than 330 meters at the first time. Now let me remind you that normal individual, normal man for example, can walk for about 500 meters, 550 meters, 600 meters. Normal woman, a little bit less, about 500 meters. So those people are have restricted exercise endurance. Again, those who fail to respond to 3 months of treatment, that they cannot walk 380 meters, after 3 months of treatment, they don't do well, and they have a higher mortality. Now, echo, we did talk about really echo, and I think it's now clear, hopefully, that it is not diagnostic tool, it is a screening tool, but echo is of great benefit when you follow the patient. And we look at special markers, such as right atrial size, and those who have right atrial size above the median, they have worse outcome. Those who have pericardial effusion, they have worse outcome because indicate florid heart failure. Those who have those who have basically high tie index and low TAPSE measurement, again indicating low right ventricular function and worse outcome. So echo is extremely important in following the patient. BNP level as a marker for the right ventricular really stretching is another good marker for survival, in the way that we know that those patients who have a BNP level initially more than 150, they don't do good. They have worse outcome than those patients who have lower BNP level. So all these markers should be considered when we are dealing with those patients. But again, let me re-emphasize that we do not treat patients until we do right heart cath. because all of other markers are very good, they are helpful, but the right heart cath is the gold standard. And during the right heart cath, beside confirming the diagnosis, beside looking for certain prognostic markers such as right atrial pressure, the cardiac output, the PVR, etc., we do what now you learn about the vasoreactivity. Basically, we are checking if those patients having vasoreactive vessel, i.e. muscular spasm, or they have, as a matter of fact, fixed vessel, i.e. remodeled fibrotic vessels. It's very clear that those who have vasoreactive vessels, which is muscular spasm, they have better outcome. And actually those are the patients who they can treated by calcium channel blocker. Only those patients who have vasoreactive cardiac cath can be treated by calcium channel blocker, because now you are treating the vasoreactivity, the vasoconstriction. Those who have fixed vasculature or negative vasoreactive, calcium channel blocker is contraindicated. As a matter of fact, it is indeterminate. It can kill the patient. So if you would like to take a message from me tonight, no empiric treatment with calcium channel blocker. You should always have vasoreactivity to document the vasoreactivity before you start calcium channel blocker. If you ask me what's the percentage of the patient that they will have vasoreactivity, I'll say 5%. So vast majority of your patients, when you see them, they will be already advanced fibrotic, non-calcium channel blocker responsive. However, if the patient is vasoreactive, that's good news. And as you can see, the survival is actually great. The 10-year survival is about 90%. Those patients do the best if you treat them. Anticoagulation is extremely important. And at least the data from the idiopathic pulmonary arterial hypertension, group 1 or class 1 basically patients, all of those patients should be anticoagulated unless there is contraindicated. And this recommendation came from 2 randomized controlled trials. The important one came from basically Stuart Fritch in the New England, where showed that those who get anticoagulated get better outcome. And that makes a lot of sense, because we know that those patients, they have in situ thrombosis as part of their really pathophysiology. Now let's talk about the targeted treatment, which is the specific treatment for the pulmonary hypertension. And that's the guideline, and that's the cascade. At the moment, we believe that there's 3 at least, of course there's much more than that, but the 3 pathways that we can target with the treatment are the endothelin pathway, nitric oxide pathway, and prostacyclin pathway. The endothelin pathway is the pathway where the endothelin-1 stimulates endothelin receptors, causing vasoconstriction and stimulate the proliferation of the smooth muscle. So it is remodeling agent. So we now have medication that can block this pathway, and so it causes vasodilatation and inhibit the remodeling. The other group are the nitric oxide pathway that go through the L-arginine system, stimulation of the nitric oxide in the presence of certain enzymes that we're going to talk about later on, can accumulate cyclic GMP, which is the vasodilator. So nitric oxide pathway is an important pathway, and the important drug that works on this pathway is the sildenafil or the Viagra. The third pathway is the prostacyclin pathway, which is as well work as vasodilator. It's also anti-inflammatory. It's also anti-remodeling agent. So this is a very important, basically, pathway in dealing with those patients. So those are, at the moment, the 3 pathways that we are targeting in treatment. Now let's take it one by one. The first group is the endothelin pathway, and the first drug that was released in the market, FDA approved, is the bosentan. And bosentan, it really blocked the endothelin through a blockage of the endothelin receptor, basically A and B. And by doing that, the first BREATHE-1 basically trial showed that bosentan, those patients who used bosentan, they had far better improvement in the 6 minutes walk distance as a surrogate marker for cardiac output improvement, if you like, compared to placebo. And we look at the composite endpoint, where the worsening of their illness, as indicated by basically hospitalization need for lung transplantation, etc., those who were on bosentan had far less event than those who were on placebo. So based on the BREATHE-1 trial, FDA approved bosentan as one treatment through inhibition of the endothelin receptor pathway. The second class, as we said, is the sildenafil, and this work on the nitric oxide pathway through the inhibition of the phosphodiesterase 5 inhibitor that usually break down cyclic GMP. And the data done by Gallet and Ghofrani showed that sildenafil used in 3 different dosing, 20 milligram TID, 40 milligram TID, 80 milligram TID, were superior to placebo in maintaining the 6-minute walk distance. So those patients walk much better when you give them sildenafil for 12 weeks. However, only the 80 milligram TID showed durability for 1 full year. It seemed that 20 milligram and 40 milligram, they lose their effect over time, and you need to keep increasing the dose because of the tachyphylaxis. Now the third group of medication is the prostacyclin. And as I said, prostacyclin is unique because it's not only vasodilator, it's not only anti-remodeling, but it has 2 important more characteristics. They have some anti-coagulation if you like, effect through inhibition of the platelet aggregation, and it has anti-inflammatory mediators. So now there is a lot of data to show that there is a lot of really invasion of the vasculature by the lymphocyte and neutrophil, and prostacyclin is one of those drugs that inhibit a lot of the mediator released by these drugs. And those drugs were the first drug to show survival advantage. If you look here, this data from the late 80s showed that IV prostacyclin at least doubled the survival. The 3-year survival improved from 34% to about 62%. So this class of medication were the first class of medication to show survival advantage. And some of those patients were actually taken off the transplant list because they were doing far better clinically. However, the infusion form of the prostacyclin is not without problem because it needs an infusion pump, it needs 24-hour infusion, and any interruption of the perfusion can lead to rebound hypertension and even death. So it will need significant follow-up. Also the site infection, the side effect of the systemic hypotension sometimes, the tachyphylaxis that you need to keep increasing the dose over time because of the continuous stimulation of the receptors, and the cost, of course, were really a problem. So the second prostacyclin analog, inhaled iloprost, came as with very specific advantages, that it is basically selective, it has very minimal systemic side effect, better cost, no tachyphylaxis. The only problem was frequent inhalation, that the patient need to take 6 to 9 inhalation to maintain the effect of the drug because it is basically short-acting. When you look at the data about the efficacy for the inhaled iloprost, comparing it with the nitric oxide in the cath lab, inserting swine glands and give nitric oxide, then flush and give iloprost, found that iloprost was better in dropping the PA pressure more than nitric oxide, dropping the PVR, the pulmonary vascular resistance, far more than nitric oxide, and improving the cardiac output and the mixed venous oxygen saturation better than nitric oxide. Not only that this drug not only has this acute effect that was maintained in 3 months' time, that even after 3 months there was significant benefit when you look at the PA pressure, the cardiac output improvement, and the PVR improvement. So there was no tachyphylaxis that you get with the IV prostacyclin that you need to keep increasing basically the dose. And the AIR study is the study where this drug get the FDA approval, because besides its effect in the cath lab, it showed clinical effect by improving the 6-minute walk distance significantly compared to placebo, and again there was trend towards survival improvement and decrease the worsening event significantly compared to placebo. So I would just like to show this study because I like this paper. This paper we're looking at those patients who were desperate. They were very, very severely ill. And those patients, if you look at them, they had very limited 6-minute walk distance. Their CVT was extremely high. There was cardiogenic edema. and they would have hepatic renal failure, cardiogenic somnolence. So they were very advanced cases of the pulmonary hypertension. And you look at it, about 12 patients were in the idiopathic, 3 patients were in CREST or scleroderma related, 2 patients were in class 3, 2 patients were in class 4 chronic thromboembolic. And they were treated with aggressive course of ileoprost. Now remember that those were dying patients. And as you can see, more than 1/3 gets significant improvement, another third basically stabilized, and 4 patients died. Now remember, as I said, that those were dying patients. When we follow them up for 3 months, their 6 minutes walk distance improved dramatically by about 200 meters. That was very good. And their cardiac output improved significantly as well, indicating that this drug can be used as rescue drug in severe cases. So if you look at our guidelines at the moment and the algorithm, how we treat those patients in class 2, 3, or 4 NYHA, we give them the general care, basically oxygen, anticoagulation, etc. Everybody needs to have acute vasoreactive. If they are vasoreactive, they can go for the calcium channel basically blocker. If they maintain the response, that's fine, they can continue. If they fail to show vasoreactivity, they should go to the target treatment, either the endothelin receptor antagonist, phosphodiesterase inhibitor, or the ileoprost. Those who are in class 4, they should be treated with the IV prostacyclin. This is because this is the only drug which was showing survival advantage in those class of patients. Where the future is taking us? I think now we are going to one step ahead. We are going to the combination therapy, transitional therapy, which is the gene therapy. Now we are treating early patients. We are picking early patients, and there's a new target as well. I'll just show you one study on the combination treatment. Those are the patients who were on ileoprost, and as you can see, there is significant improvement in the 6 minutes walk distance that was stabilizing in about 3-4 months. Now adding sildenafil give you added benefit, and that was one of the earliest basically paper that showed there is some synergism between these two drugs. There's another few study, like as basically SIP study, combining the bosentan and the ileoprost, again showing very active endpoint. However, this is not the end of the disease. This is actually one of the most advancing field of respiratory basically medicine, and as you can see, in the near future, you will have lots and lots of other endpoints and targeted that we will be targeting with treatment. Allow me to show you one of them, because this is going to be available in very near future, and those are the soluble guanylate cyclase stimulator. How this drug works? We said that the nitric oxide, in the presence of certain enzyme, will really accumulate cyclic GMP, which does most of the good work. Now cyclic GMP will be broken down by the phosphodiesterase enzyme, and that's where sildenafil basically work. However, there's other enzyme that maintain the cyclic GMP is the soluble coagulase cyclase stimulator. And this drug it's now basically named riociguate is the drug that will stimulate this pathway and hopefully will accumulate more cyclic GMP. The initial data showed that this drug works very well on the idiopathic form of the PAH and on the really chronic thromboembolic PH, that the cardiac index improves significantly compared to nitric oxide by using the riociguate. So take home messages. Few messages here. I would indicate again that the disease, although it is not common, it is not rare. We are diagnosing about 1 patient a month. So that's not really a rare or orphan really problem. The vasoreactivity may indicate early process that can be targeted by vasoreactive agent, i.e. the calcium channel basically blocker. But there is other mediators such as endothelin, nitric oxide, and prostacyclin that can be targeted with treatment as well. Echocardiography, that's fine, I'm fine. Echocardiography is the screening tool. It's not the diagnostic tool. It's good to follow up the patient, as well as the 6 minutes walk distance, the functioning class of the patient, the BNP level, and the echocardiography definitely. However, the cardiac cath is the diagnostic test of choice that should be done before treating every patient. I think we have good drug. We improve the outcome of the patient. We improve the survival, the quality of life. We haven't cured the disease yet, but hopefully we'll be able to do that in the near future. Thank you very much. Right. Now the atrioseptostomy is actually one of the bridge therapy for transplant because you gain some time when you do it. There is no data to show survival advantage by doing atrioseptostomy. And plus that you will need a center and you will need a cardiologist who has the gut to go ahead and do it because those people are extremely sick. We have experience of 2 patients. One of them died actually, one of them feel better. The idea of the atrioseptostomy is to debulk the right ventricle, so inducing atrioseptal defect. So now basically some of the venous return of the right ventricle, of the right atrial will go to the right side, left side. Of course, what you are doing, you are making the really oxygenation worse because now you are creating basically shunt. But because you are improving the cardiac output, so you are in general improving the oxygen delivery. So really, despite the hypoxia that happened, you are improving the oxygen basically delivery. So the trick where the cardiologist should be very careful is how big is the hole, because if he does very big hole and induce a huge shunt, there will be severe hypoxia and real problem. And if he does very small hole, that will not be efficient. Okay. Of course, if there is foramen ovale and it is already there, that's fine. So we are happy. But if there's no foramen ovale, we induce one. But the trick is what the big size. The usual size is about 3 millimeters. But there is no guarantee because sometimes this can go. So you need very, very brave cardiologists actually to do it for you. Yes, please. Okay. Thank you.
Before starting this session, I'd like to thank Professor Tariq Safar and Professor Tariq Mahfouz for inviting me to share this very nice meeting. And we start with Professor Amjad Farhat, who is going to present to us asthma and COPD are two phenotypes of one disease.
بسم الله الرحمن الرحيم. Mr. Chairman, ladies and gentlemen, اسمحوا لي لو سمحتم في عجاله ان انا اشكر الاستاذ الدكتور طارق صفوت والاستاذ الدكتور طارق محفوظ دعوتي لحضور المؤتمر السنه دي، واحب يعني انوه على حراره اللقاء وحسن الاستقبال اللي احنا اتقابلنا بيهم. الحقيقه ديت سمه واضحه قوي في المؤتمر هنا، بنشكرهم عليها جدا من اول ما قابلونا في المطار لحد في اي مكان، فشكرا جزيلا على حسن استقبالهم لينا الحقيقه. وبرضه بشكر شركه نوفارتس اللي هي السبونسر للسيشن اللي احنا موجودين فيها ديت، وارجو ان المحاضره اللي هقولها النهارده يعني تمس شغاف القلوب، لانها من الكلينيكال اكسبيرينس، ونجعلها زي ما يكون محادثه بيننا وبين بعض كده عن الازمه والسي او بي دي اللي احنا بنعالجهم بسبب علاج واحد وان تريتمنت، لكن بنعتبرهم تو ديفينيت ديزيز. مين اللي له مصلحه ان هم يخليهم تو ديفينيت ديزيز؟ هل الجينا والجولد وكل واحد فيهم بيدافع عن حقه في ان هو تبقى definite entities، ولا الايفيدنس بيزد ميديسن؟ الايفيدنس بيزد ميديسن لو احنا بنراجع الليتريتشر اللي موجوده في خلال الاربع او 5 سنين اللي فاتوا دول، هنلاقيهم كنترولد ب5 بيرسونيلز على مستوى العالم: بيتر بارنز في انجلترا، وبوسكيه في فرنسا، وماكونكي في المانيا، وكوبر في امريكا، وباتمان في جنوب افريقيا. معلش انا بسمحوا لي ان انا بقول الاسامي، لكن الحقيقه ديت حاجات احنا كلنا بنعاشرها. كلهم مسيطرين على كذا